The first presenter will be presenting intracranial lesion leading to visual impairment in Aba, Southeast Nigeria. Are you around? Is there any of you? The second presentation, women's right to information, worthy. Okay. Worthy. On early objections of breast and cervical cancer. Okay.
Good afternoon. I'm Dr. Uche Chukwuka Nnemdi Okwe, the Worthy Coordinator and MWAN National Assistant Secretary. I'm here to present the Worthy project on early detection of cervical cancer and breast cancer. This next slide, please. Well, I didn't conduct the study. I'm actually the coordinator, and then we have the co-authors who actually did most of the job. I was just coordinating and got this report. Next slide. We all know that in sub-Saharan Africa, many women have very poor knowledge of breast and cervical cancer, its risks, and the need for screening for prevention. Breast and cervical cancer constitute the two leading causes of cancer deaths among women in Nigeria. 1.7 million breast cancer patients were recorded globally in 2012, accounting for about 25% of the world cancer burden among women.
Please, 1 minute, Dr. Okay.
Yes,
you have 10 minutes.
Okay, ma.
10 minutes.
All right,
please.
ma.
Just
well,
go straight.
In Nigeria, we already know 187 million persons represents about 12% of all new cases and 25% of all cancers in women. Breast cancer is more hazardous and affects the quality of life of people. It tells a 5-year survival rate of about 85% and 10-year for 71%. However, early detection and effective treatment can lead to improved survival rate. More than 90% of breast cancer patients seek medical attention only at advanced stages and consequently detected clinically. The screening methods like mammogram and BSC help people in early detection. At about 77% of people, we are still unaware of breast cancer from the studies we have read. Next slide, please. In Nigeria, the uptake, I'm going on to cervical cancer because I have to talk about breast and cervical cancer. In Nigeria, the uptake of cervical cancer screening has also been demonstrated in various studies. Out of 13 studies, 9 show cervical cancer screening uptake of less than 5.3. About 70% of cervical cancers, we all know, are caused by HPV and is linked to social poor standards of living with high mortality rates in developing countries. Financial difficulties cannot be ruled out. And then cervical cancer happens to be the 4th most common cancer affecting women worldwide and most notable in low and middle income countries. There were 31,955 new cervical cases in West Africa in 2018, and Nigeria accounted for 14,943. There were also 10,403 deaths observed from cervical cancer in the country in the same year. Next slide. So the objectives of this was to reach out and assist women who are financially unable to have a cervical and breast cancer screening done, to assist women who need prompt treatment after screening and testing positive, and to educate women and men on breast and cervical cancer. To also treat, follow up, and record the resultant reduction in mortality of women with breast and cervical cancers, and then to build capacity and train female doctors on various procedures for screening and treatment for breast and cervical cancer, as this will boost a reduction in mortality in women. Next slide. The methodology is the medical women we know are in 36 branches of the country, and this descriptive and non-experimental project had responses from M1 branches in 19 states and FCT. We can see the states here. These states indicated interest in assisting women with breast and cervical cancer who were unable to screen and treat themselves due to financial upheavals. There was education of women during the period we did this project, and the screening in outreaches conducted were in various health and social facilities. Flyers of breast and cervical cancer information was distributed, and the number of participants were also recorded. Various cervical lesions was equally recorded. Next slide, please. Next. We can actually see all that we calculate, that's all that we saw, and all that was submitted to us from all the state presidents. Continue. Next slide. Next, please. The Worthy Project on Cervical Cancer commenced in 2020 with 16 states and FCT. We can see that 8,000 from the data, 8,787 males and females were reached in various health facilities. Financial support were given to 7 states who needed flyers and cervical screening in their outreach programs. 3,087 women were equally screened. 1,376 women with cervical lesions were recorded, and 328 that were positive for VIA/VLI benefited from LEAP, thermal ablation, and cryotherapy. 259 calls were equally recorded. 3 states benefited from financial support for treatment for cervical cancer. It was because of this that the national president actually had a 3-day training on VIA and thermal ablation. More than 330 members actually participated virtually. Members from 5 geopolitical zones interested in practical training were nominated and enlisted, and then participants were from 14 states. This is the data for BSc breasts. Continue, please. And then the next. This is a picture showing some of the sensitization programs in outreaches we went to. Please. Next. The Worthy Project on Breast Cancer also started in 2019. We can see that various outreaches indicated that 12,644 participants were there, 7,004 BSc flyers were distributed, 1,440 breast lumps were identified, and then 360 cases of breast cancer were diagnosed. 78 calls were also recorded. Training in the outreaches were given on BSc and all the outreach in all the outreach programs. 4 states benefited from financial support by the Secretariat to initiate cancer treatment for women who needed financial support for breast cancer treatment. The states were Delta, Cross River, Benue, and Osun State. Please, next slide. There were limitations. We cannot rule out limitations. The limitations were the delay in submitting monthly data by states to the Secretariat for assessment. Even though MWAN branches were in 36 states, 19 indicated interest in participating in the Worthy Project. Incomplete information submission on Worthy Project in some states that participated, despite the templates that they were supposed to submit. No response from some states on keying into getting funds for flyers and treatment for cancer patients in their states. Mostly VIA and VLI screening was done in outreaches and recorded. You know that this test is not specific for cervical cancer. So we find that there is so much negative impact in cervical and breast cancer screening and all that. However, the outcome of the MWAN Worthy Project in the prevention of the scourge is commendable. 4 patients with breast cancer from Delta states and some states benefited financially for treatment. 3 patients from also some states also had cervical cancer treatment. 1 died despite treatment, but others are still alive. Please, I'm almost finished. So from the results, we can make an inference that breast and cervical cancer is a leading cause of increase in the mortality of women and the burden in Nigeria. It has a social and economic impact on women and their families, and the disparities of cancer survival among socio-economically disadvantaged women were also seen in different settings in Nigeria. There's an urgent need for substantive and sustainable investments in cancer control, including prevention, early detection, such as BSc, mammogram, VIA, pap smear, and HPV vaccinations. Capacity building cannot be ruled out, and there is also a great need for population-based cancer registries to enable a follow-up on cancer incidence and mortality in Nigeria. Next slide. These are my references, and then thank you very much.
Thank you very much, Dr. Okwe. Please, before we continue and the next presenter come up, please, if you are the doctor that want to present on behalf of Dr. Etty, please, can you come forward?
I forgot to mention, sorry, ma, that this is ethically approved by the Federal Ministry of Health.
Thank you. Please, if you are here representing Dr. Etty in our presentation, just come forward. Thank you. We will have the next presenter, Dr. Lewechi Uke. She will be presenting abdominal obesity, serum estradiol, and cardiovascular risk among Nigeria post-menopausal women. I'm sure half of the people here are moving towards that. Thank you.
Good afternoon, everyone.
You have 10 minutes, and your time starts now.
Please, can I have the slides projected? Yes. The title of my presentation is Abdominal Obesity, Serum Estradiol, and Cardiovascular Risk Among Nigerian Postmenopausal Women. The study was carried out by the names shown on the screen. I'm Dr. Lewechi Uke Omolara. I'm a consultant family physician with Federal Medical Center, Abeokuta. But this study was done in University College Hospital, Ibadan. Cardiovascular diseases form a significant proportion of non-communicable diseases, just as we all know. And rates of cardiovascular disease mortality is usually higher in men, but this is known to equalize with that of women following menopause. And so this study sought to determine the contribution of abdominal obesity and serum estradiol to cardiovascular risk in postmenopausal women, as well as to estimate their cardiovascular risk using known cardiovascular risk calculators. The markers of cardiovascular risk of interest for this study were presence of hypertension, presence of diabetes mellitus, and presence of dyslipidemia as measured by components of the fasting lipid profile. Next slide, please. It was a cross-sectional study, hospital-based, that was conducted at the General Outpatient Clinic of University College Hospital, Ibadan, and 271 consenting postmenopausal women were selected consecutively after obtaining informed consent. Data was collected using interviewer-administered questionnaire. Blood pressure and anthropometry measures were checked, specifically the weight, the height, and their BMI. Waist-hip ratio was calculated. Waist-hip ratio was the anthropometric index used to measure abdominal obesity. Laboratory analysis of their fasting serum lipid profile and estradiol was also done. I'm not yet on this slide. So also, ethical approval was sought and obtained from the UCH/UI Ethical Review Board, following which we got the results shown abroad. I'll be shown on this slide. The mean age of the participants was 57.8 years, and table 1 shows the clinical characteristics of respondents. We saw that the mean BMI of respondents was 28.2, and the pie chart shows the pattern of obesity among respondents. We found that just 1.8% of respondents were underweight, while as high as 38% of respondents were overweight. Similarly, about 37.6% of them were obese. This shows that we had a high prevalence of obesity and overweight among postmenopausal women. Next slide, please. Also, we found a statistically significant association between presence of hypertension and the risk of abdominal obesity. When we looked at diabetes and hypertension, we did not find any statistically significant association between presence of either and their serum estradiol level. Now, we found that looking at the relationship between risk of abdominal obesity and the components of the fasting lipid profile, we found that there was a weak positive correlation between their triglyceride level and the risk of having abdominal obesity. Meaning that for women, the higher the triglyceride level, the higher the risk of having abdominal obesity. While for HDL, the reverse was the case. The higher the HDL, the lower the risk of having abdominal obesity. This is not unexpected, as we know. I mean, this finding is in keeping with with what we've known, with existing knowledge, that we know that HDL is the good cholesterol, in quote. The next slide, please. We estimated their cardiovascular risk using the premium risk score and the AIP, atherogenic index of plasma. We now compared the estimated risk score using these two calculators. We found out that the AIP was more sensitive because it estimated up to 80% of participants as having high risk. While using the premium risk score, it was just about 30% of participants that were estimated as having high risk. And also, there was a weak negative correlation between their estimated risk score using the premium risk score and their serum estradiol level, meaning that the higher the serum estradiol level in participants, the lower their risk, their cardiovascular risk. Next slide, please. Following regression analysis, age group, ethnicity, and waist hip ratio remain significantly associated with hypertension. In fact, for participants that were over 60 years of age, we found that they were at more risk, about fourfold. They have about fourfold higher risk of developing hypertension when compared with participants that were less than 50 years of age. Also, 10-unit increase in waist hip ratio was associated with about twofold risk of developing hypertension. And the higher their age, the higher the total cholesterol level. And also, decrease in serum estradiol level was associated with increase in total cholesterol. The next slide, please. Yes, conclusion, thank you. In conclusion, next slide. Abdominal obesity and serum estradiol, as found out from this study, still significantly influence cardiovascular risk in women. Also, this study also established again that the AIP is a more sensitive cardiovascular risk calculator in comparison to the Framingham risk score. And in addition to the known traditional markers of cardiovascular risk, I want to suggest that there is a need for new cardiovascular risk estimators that incorporates factors that are peculiar to women, such as the serum estradiol level, use of OCP, history of pregnancy complications like eclampsia, preeclampsia, and postmenopausal use of hormonal therapy. Thank you.
Thank you for keeping within your time. Please, can we give her a round of applause? Thank you. We take the third presentation from, it's supposed to come from Dr. Eti A. It's awareness of cervical cancer and its prevention among women in Benue State. But this presentation will be given by a colleague, Dr. Chiza Uguaja. You have 10 minutes. Yes, your time starts. Please, can we have the presentation up? Dr. Eti is hello. Hello. You didn't clean the you've done. Dr. Lequit. Which I gave you another name. Who is the next person. Please, if the presenter for, hello? Please, if the presenter for intracranial lesions leading to visual impairment in Aba, Southeast Nigeria is around, please, can you come forward? The presenter for intracranial lesions leading to visual impairment in Aba, Southeast Nigeria. Or if there is somebody presenting on our behalf. Please, let's exercise a little patience while they sort the presentation. Oh, she's saying. You can go. Okay, Dr. Ogbuaja Chisa is one of the authors, so she will be presenting. Your time starts now.
Okay. Good morning.
Please, one out.
Okay. Good morning. Good afternoon, everyone. I'm Dr. Chisa Ogbuaja from MWAN Benue State, and I'll be presenting awareness of cervical cancer and its prevention amongst women in Benue State. So, as we all know, cervical cancer is one of the most common cancers, or is the most common cancer of the female genital tract, and is a leading cause of female cancer death, especially in the developing world, where more than 80% of the deaths from cervical cancer come from. And it's preventable, yet ignorance and lack of access to prevention services has made it a serious burden on us and a huge public health concern in this part of the world. This study aims to assess the awareness, the knowledge of risk factors and prevention, as well as screening practices among women in Benue State. And it was done from a cross-sectional study of 350 consenting women, which was carried out during a mass campaign. We did a cervical cancer screening campaigns in Benue State, and 350 consented to do this with us in order to create awareness on cervical cancer. Relevant data was obtained using an interviewer-administered questionnaire, and it was analyzed using SPSS 20. The results are as follows. Now, for the age group, the highest number of people were found in the age groups between 35 and 44, and the marital, 80% of the women were married. Most of the women in this group, the participants, had tertiary education, about 38% of them. The rest were as follows. The list were those with no education at all. Most of them were unemployed, and we had about up to 40% that were self-employed. The ethnic groups were mostly Tiv, 46.6%, and Hausa, about 33.1%, and the rest were as follows. We had almost an equal mix of Christian and Islam, with 53.7% Christian and Islam being 46.3%. And most of these people, up to 95%, were urban dwellers, as opposed to 4.3% rural dwellers. The age, when we're looking at the reproductive characteristics of these women as relates to the risk factors for cervical cancer, we find that age hierarchy for most of the women were for all the women were between 11 and 19 years, and the mean age was 14.2. The age at Koitaki was 13 to 29 years, and the mean of 18.8 years. The age at menopause was 35 to 52 years, with a mean age of 45 years. And the number of lifetime sexual partners amongst our respondents were 1 to 10, and with a mean of 2.4. So about 80% of our respondents were aware of cervical cancer, while 20% were not. And this was very interesting to us because it shows that there is a lot of awareness in our population of cervical cancer. Most of them found out about cervical cancer from media, including mass media and social media outlets. Then there were also campaigns, awareness campaigns, such as the ones we staged, 22.1%, and then the rest from friends, family, and the list was from hospitals. However, it's important to note that we asked them for multiple answers, so they could give as many sources as they could. And then their knowledge of, their practice of cervical cancer prevention was found to be that 31.1% were aware that's 109 out of the 350 women, were aware that cervical cancer was sexually transmitted. Then about 55.7% of them had heard of cervical cancer screening. That's more than half had heard of cervical cancer screening. Then most of them, those that heard of it, had known about pap smear. Very few knew about visual inspection with acetic acid, which we were actually using to test them. And HPV testing was only known by one person. Only about 39 persons out of 350 had ever had a cervical cancer screening in the past. And of all our women who testing the knowledge of the sources of their knowledge of cervical cancer screening, most of them had heard from hospitals and campaigns and friends, and also media. Few heard from friends. So then, in conclusion, though many people had heard of cervical cancer, the knowledge of the cause, prevention, and screening, as well as uptake of screening, was low. We need to urgently escalate mass education and improve access to screening, cervical cancer screening in our society. Thank you very much.
Thank you, Dr. Ogwaja. We want to thank the presenters for their beautiful presentations. Please, can we give them a round of applause again? Please, can you people come to the table? Please, just pull a seat and come. Just come to the side. Come with your team. The rapporteur will be giving a summary of the three presentations. I think it's okay. It's not. Is it done?
Yes, thank you very much, ma'am. So we had three presentations in all. The first presenter spoke about the women's right to health information worthy on early detection of breast and cervical cancer, which was presented by Dr. Okwe. So she spoke to us about the high prevalence of breast and cervical cancer in Nigeria, and also the importance of early detection of breast cancer as well as cervical cancer as a result, because of their associated high morbidity and mortality rate. So the study found out that there was low uptake of breast as well as cervical cancer amongst the population, and they assisted women that had low financial capabilities
to be able to access cervical cancer screening especially. And the VIA was done for them, and also breast self-examination. And some of them also were given some form of treatment to help them with their conditions. So they suggested that the government should provide a population-based cancer registry so that we can have proper documentation as regards cancer reviews in Nigeria. The second presentation was by Dr. Lewechi, and it was on abdominal obesity, serum estradiol, and cardiovascular risk among Nigerian post-menopausal women. So she made us understand the significance of cardiovascular diseases causing or leading to a high proportion of non-communicable diseases, and also the correlation of abdominal obesity and serum estradiol in this situation. So our study found out that there was high prevalence of overweight and obesity amongst postmenopausal women that happened to be the study population. So, and there was also the association of this abdominal obesity and serum estradiol to the CV risk amongst these women. So they suggested a need for new CV cardiovascular risk calculator, which is actually important for women as a peculiar population. The third presenter was by Dr. Ete, and it was on awareness of cervical cancer and its prevention amongst women in Benue State. So the study was a cross-sectional study that assessed the awareness and screening practices among women in Benue State. And they found out that despite the high knowledge of cervical cancer among these respondents, there was a low uptake of screening practices. There was low uptake of screening practices for cervical cancer amongst this particular population. Thank you very much.
Thank you, Dr. Salau. I think we all know about World Day campaign. I think M1 has been at this campaign for so long. It has always been what we work on. Can we have questions, please? You can go ahead because our time is fast spent. Can we have questions? Anybody with questions or comments? Okay, ma. Please, you can come with your comments, with your questions.
My comment is based on self-medication. Sometimes you are forced to do so. The protocol to see your colleague formally in the hospital is not today. Take card, go and pay there, go and do this there. It's not easy. I don't know how else we can do it so that if you want to see your colleague formally, it will be simplified.
Thank you, ma. Actually, that was the recommendation of the paper, that we should find a way to make it simpler, make it easier. But I think in some places, if you walk in as a colleague, some people will oblige you. Some consultants will oblige you. Yes, we can also help you through that too. In my place, if you come, we could help you. We can do that for you. But some of us also walk in, we don't introduce ourselves sometimes, and then we enter the bottleneck, and then we say, I won't come here again. We all know that some of these systems are put in place to check some of these things, but it's the hospital system in Nigeria. But we should please not let that deter us from visiting hospitals, because self-medication has its own detriments. Thank you. Any other comments? And what is very glaring is that actually M1 has been working on providing information on health. Providing information on health. And we also learned from the two presentations, the one on World Day and then the one from Benue. A lot of people have heard, they have been told, but they are still not taking the preventive measures. They are still not going for pap smear, and they are still not observing their self-breast examination. And if I can ask, even in this auditorium, I'm sure if we do a survey here, we will say that half of us have not done maybe in the last 2 years. Mine is not like that too. I hope that's not how you do self-breast examination. So we'll still find out that even among doctors, among health workers, we are still not doing. So I think that we will continue as medical women to preach it. Is our preaching, is our sermon. We will keep giving the health talk. And from what we saw, if about 30%, 50% are taking it, we know that if you prevent the death in 50, maybe with time it will go to 70. And we'll know that M1 has done a good job in giving the information about these female cancers that are increasing the mortality and morbidity in the women in our sub-Saharan area. Thank you very much. In the absence of any other questions or you want to talk? You can talk. Okay. Thank you. Then I want to please, as many of us that are post-menopausal, we should also try, because that's why we have had a talk on post-menopausals, the abdominal weight, the obesity tend to to increase in that age group. So we should try maintain our weight. We are still very, very relevant in the scheme of things. We should not let go and say, who is looking at me? A lot of people still need you. We still need you in M1, and we should also preach it among our friends, our different clubs, so that we can take good care of ourselves at that age group. So thank you very much. The presenter, please can we give them a round of applause? And thank you, LOC, for these beautiful topics that has come forth for our enjoyment this afternoon. Thank you.
Distinguished delegates, please join me to give Dr. Ijeru and her team a round of applause. Thank you so much. So please remain seated while the next item is a drug presentation, which will be taken virtually. So our media team will load that right away. And after that, we'll go for lunch. Thank you for your patience.
can you hear this one? Check the audio.
Ezekiel, please, you have the floor.
Hey. Good afternoon, everyone. I wish to continue on existing protocol. Thank you so much for having us here, Ma. And thank you so much, our wonderful doctors, for being here at the M1 conference. My name is Priscilla Awushino, and I'm the co-presenter today. And with me is
Solomon Anga. I'll also be supporting him.
All right. So we'll be presenting on easy care, and we'd like to have our slide displayed on the screen, please. Hello, can you hear us, please?
We can hear you.
Okay, Ma. Please, can we have our slide displayed on the screen,
Yes,
or
we're
can we
loading.
share our screen here?
We're loading your slides right now.
Okay.
Right.
Thank you. Next slide, please. Thank you. So easy care, what's easy care? Our core identity is healthcare at your command. Easy Care is a total healthcare app that links healthcare professionals to healthcare seekers. Its main purpose is to help everyone in Nigeria have easy access to healthcare in general. We understand that there's an increased mortality rate across the country because there's no easy access to healthcare in general. So this presentation is centered on telling us about what Easy Care is all about and its core mission and vision. The next slide, please. We understand the Nigerian doctors are the best in the world. We understand that we invest so much into the system to ensure that everyone has quality care and everyone has easy access to healthcare in general. So we have wonderful doctors in Nigeria, and we women are not an exception at all. We've made our names in history, and the popular saying that goes, it says, girls run the world. And we've seen it in existence. We've seen it work out in every sector in Nigeria. And coming down to the medical sector, we've seen women excel in all careers, in all ramifications, across all specialties in the medical system. Our women are highly skilled, very hardworking, but there's a problem. They're not as paid, the payment that they give to them, they're not worth it. It's not enough. It's not enough for the healthcare providers. It's little. Now, Easy Care is bringing a solution to this problem. It's taking advantage of the soft skills of the doctors and how the doctors can actually make money from these soft skills that they render to the patients. Majority of our doctors are not very business savvy, and it's a normal nomenclature in the medical profession. We are not business savvy. But Easy Care has come to make sure that everyone has access to healthcare, and at the same time, doctors are being paid for the services they render to the healthcare seekers. The world is moving today as a shared economy. Please, next slide. Now, what is Easy Care in detail? Easy Care is like an Uber-like app that connects patients to the nearest healthcare providers for various types of consultation. So Easy Care has 3 types of consultation. One is the physical consultation, the video consultation, and then the clinic consultation. Now, it works just like the Uber app. You have doctors situated in an area, and then there are healthcare seekers seeking for healthcare, and they can have access to these healthcare providers. Now, Easy Care is a problem solver for both the doctors and the healthcare seekers. Now, for the doctors, we understand that most doctors don't get paid for the services they render. Take a situation like this. A person that is looking for healthcare can just contact the doctor and say, hi, ma, I'm having this so problem. Maybe he's having symptoms of malaria. And then you give an advice. Okay, go to the test, go to the lab and have this test done. Go to the pharmacy, buy so drugs. Now, in that kind of scenario, the doctor doesn't get paid. He or she goes to the lab test, to the laboratory scientist. He runs tests. He or she pays for that test. Goes to the pharmacist, buys drug. He or she pays for that drug. It's not free. But the doctor in this scenario doesn't get paid. Now, doctors, we offer free consultations to our patients because we believe that we're here to solve problems. We're here to give total care. We've been so educated to understand that we put our needs behind and put the patients first. But with Easy Care, you can do both at the same time. Now, you can offer care, but not at a free cost. You need to get paid. You are worth the service you render. And then you need to collect the money that you are worth. When you offer services, you should get paid. Now, with Easy Care, you don't have free consultations anymore. Anyone that wants to meet you can go to the app, download the app from the App Store or the Play Store, and then book you at the time you have set for yourself, the time you'll be available for. Easy Care makes sure that you set your timings to the times you'll be available for, and then you set your own charges. It is unique. We don't set your charges for you. You set your own charges at the time you'll be available for. Now, people come on the app and then they book you for consultation, either the video consultation, the home consultation, or the clinic consultation. Now, you have total control of the pricing, like I said earlier. You determine how much you charge for every minute with the patient. And this is how Easy Care works. The patient will pay you even before the service is rendered. Now, you have total control of your time. You're not being disturbed. You know, doctors receive calls any time of the day because patients feel like they are there to help us, so I should call them at any time. But with Easy Care, you have total control of your time. Patients do not contact you outside your working hours. Now you get visibility without advertising. All you need to do is just download the Easy Care app from Play Store or App Store, and then you sign up as a healthcare professional. You upload your documents to be sure that you are actually not a fake doctor, because we have several situations of people signing up on healthcare apps and then they turn out to be fake doctors. So Easy Care takes that pain to, streamline the doctors to ensure that they are quality and top-notch doctor. So if you are a doctor in any specialty, you just sign up, download the app from the Play Store, sign up and register with the relevant document. And then you get visibility without even advertising yourself. People look for you and book you from anywhere across Nigeria. Now, this is a very important point. It provides seamless retirement plan for doctors. Once you are out of the profession or you retire, you can actually still make money from, offering consultations to patients. As you're on the Easy Care app, it has no expiry date. You can keep using it for a long period of time. The next slide, please. How do you start making money on the Easy Care app? The first step to take is to download the app on Google Play Store or App Store. So if you're using an Android phone, what you do is just go to your Play Store, type in EZZYCARE, and then search by yourself. Use the search button and search for the Easy Care app, and it comes up. Easy Care, EZZYCARE. What you do is sign up with your number, your email address, and the steps are seamless. They're easy to understand. You register with relevant documents, after which you'll be verified, and then you can start making money. It's that easy on Easy Care. The next slide, please. Now, I want you to take a step further to download the app. My colleague is here to actually take us through how to download the app in a more detailed format.
So to download the EasyCare app, if you're actually using an Android phone, you can just go to Play Store and then you search for EasyCare. That's EZZYCARE. So many options will pop up for you, but don't select it. Just tap on the search button and then the EasyCare app will appear. There you can click and then download it. Once you download, you open the app, you see care seeker and then care provider. You sign up as a care provider because you're here to provide care. So once you sign up, input your number, your phone number, skip the first zero. Once you skip the first zero, input your number, and then you should be able to get an OTP for verification. So the other processes are quite straightforward. You can just fill the forms, enter the necessary details, so we can actually do our verification. So it's actually the same thing too on App Store. That's for those using iOS. That's Apple phones. Once you just type EZZYCARE, don't select the options that will appear as in automatically. Just once you type it, click on the search yourself. It will appear EasyCare. Because when you type EasyCare, some options come up which might not be what as in our own EasyCare. It might be EAZY or EASY. So it's best for you to type the full word EZZYCARE and click on the search yourself. Then download, open, input your phone number. Ensure you skip the first zero so you can get an OTP for verification, and then you can proceed with the rest. Once you input the necessary details, we will do our verification here and then approve you on the platform. You can start taking consultations and making money.
Thank you. So the floor is open for any questions that you may have. We're here to take your questions. If you have any questions, you can leave us a question. We'll be here to take your questions. Hello, Ma. Can you hear us, please?
Thank you. Thank you, Easy. Please, do you have questions for our presenter, EasyCare? Is there anyone with a question for the presenter?
Please, is there any payment attached to this? In using the app?
The download process, getting the app is actually free. But for every consultation you do, EasyCare will take 22% for every patient we bring to you. Yes.
More questions, please. No more questions. Okay. Thank you, EasyCare. It appears you have...
Okay, we can see a couple of questions here.
Okay,
in the chat box.
Please.
Thank you so much, Dr. Ekanem Imabong. Thank you for that beautiful comment. Dr.
Ukaire Omachuku, you're asking about the role of professional associations such as Medical and Dental Council. Yeah, basically we make verifications based on the credentials you send to us. We also make verifications from NDCN to ensure that every doctor we are putting on the platform is actually qualified so that we don't put quacks on our system.
Thank you. Any other question, please?
Okay, we have
and
some
if you
questions.
want to reach us, we have our phone numbers here. We'll post it in the chat box. But for those of us that have a pen, you can just write it down. 0915 457 1363. I repeat, 0915 457 1363. We are available on WhatsApp or a call. You can just give us a call and we'll be here to help you. Thank you so much, Dr. Uka.
We have one question, one hand raised up online. Dr. Amala Chukwu Okairi. Would you like to ask your question? Dr. Okairi.
I asked my question already. Thank you.
Okay, thank you.
Okay, we have another question by Dr. Agwe Celia. Thank you so much, Ma. You said, lovely. How do you intend to enlighten the public about easy care? So my colleague can answer that question.
Okay. Basically, we have a lot of campaigns, basically on social media and other platforms, where we are giving the public information about how to access healthcare, most especially now that doctors are on strike. Patients can actually access healthcare through this app. So we have so many programs we're actually carrying out at the moment through social media, through physical campaigns and stuff to enlighten the public, where they can go on this app and look for professionals. Especially, there are people who even need specialized care, cardiologists, oncologists, and stuff. You can just go to the app. We have all these professionals on the app. So we are doing a lot to enlighten the public about easy care.
Thank you.
Okay.
Thank you, Easy Care. I think that will be the final question for Easy Care. And with that, we've come to the end of this presentation.
Thank you so much.
Thank you. It's time for lunch. Please put your hands together for them. Thank you. So it's time for lunch, and immediately after lunch, we'll be coming back in here for the next scientific session. Lunchtime. Please allow the elders to go first. Thank you for your patience.
Good afternoon, mommies, aunties, grandmas, mamas. Please, so that we don't have the same problem we had in the morning, we'll be fanning out in 10s.